Thank you for joining the session today. I'm Sarah Bechstein. I'm the Medical Affairs Manager of MSF Japan. So today's facilitator was supposed to be Dr. Harumi Yano. However, she cannot join the session today, unfortunately, due to her health conditions. So I will be substituting as a facilitator. So hopefully you will bear with me today. And then we also have one more change. I'm very sorry for the changes. We were supposed to have Miss Sarah Wanyoike from WHO as one of the presenters, but she's also not able to join today due to her conflicting situations. She might be able to join later, so we will see if she can join. However, at the beginning, she will not be able to join. So I will start the session today. So today's session's topic is vaccination. So we all know this vaccination is the most effective method to prevent infectious diseases. However, the global vaccination coverage has been significantly dropped after COVID-19 pandemic in 2019. And the rate of this coverage hasn't been recovered to the level before 2019 as of now. So this is causing a lot of lives, especially in a vulnerable population, notably children in low and middle income countries. So the aim of this session is that, and there are multiple reasons behind those. It could be long-standing issues like public health structures, also limited health facilities, limited medical health human resources, but also it could be current situations, for example, like current humanitarian crisis, increasing instability, climate change, also the US funding cut, and then also decreasing financial support from donoring countries. So aim of this session today is that we would like the panelists to share their situation, the current situation regarding the access to vaccination, and discuss the way forward, how to reach those most vulnerable in the world and leave no one behind. So I will jump into the introduction of the speakers. So the first speaker was supposed to be Miss Sarah Wanyoike, but I will leave her introduction to later if she can join. So our first speaker today will become the Miss Drew Aiken. So she's the Medical Advocacy Advisor for MSF Operations Center Barcelona and Athens. And she's also the member of Center for Applied Reflection of Humanitarian Practice. And she recently wrote this report called Vaccination Barriers in Complex Settings, which I believe she will touch upon in her presentation today. Welcome, Drew. And then the second speaker today is Dr. Keita Yoshii. So he's an epidemiologist, and also he has a background in veterinary. So he's currently working in Sudan, in the Western Darfur region, and he's in a measles project. So he will share with us today the current situation in his project from Sudan today. Thank you. Thank you, Yoshii-sensei. And then the third speaker is Dr. Kediende Chong. He's the Director General for Preventive Health Services and Emergency Response in Ministry of Health, Republic of South Sudan. So he has extensive experience in health policy, planning, and international coordination. And today he will share with us the current situation in South Sudan and government's activities regarding vaccination. And he's joining us from South Sudan today. Welcome, Dr. Kediende.
Yeah.
And then the last but not least speaker is Dr. Mugen Ujiie. So he's the head of Travel Clinic in National Center for Global Health and Medicine, Disease Control and Prevention Center. So he's the expert in vaccination and worked with Gavi before. And then he also was in DRC last year to train the Mpox vaccination, I think which he will also touch upon in his presentation today. Welcome, Doctor. Okay, so I will jump into the, before that, actually, I will have one administrative announcement. So for the participants, if you have any questions, please write them in the chat box. We will try to have a Q&A session at the end of the session. So we will select some of the questions and ask to the panelists. So please feel free to write your questions. Okay, so the first presenter is Drew.
As introduced by Sarah, my name is Drew Aiken. I'm Medical Advocacy Advisor for MSF Spain. Yes, so indeed, as introduced, vaccination remains one of the most effective public health interventions among clean water sanitation in terms of cost effectiveness and public health impact. Yet MSF and other actors continue to see a lot of challenges in terms of ensuring continued routine immunization, as well as effective responses to outbreak. As one example, in 2023 alone, there were an estimated 10.3 cases of measles worldwide, which was an increase from 2022, and over 100,000 deaths. Unfortunately, most of them were in children under 5. There were a large number of severe and disruptive outbreaks in 57 countries and 103 countries in total with outbreaks. In addition to measles, there were many other outbreaks, including diphtheria, mpox, dengue, among others. To put it in perspective, since COVID, indeed, the world has not recovered to immunization coverage rates. In 2023, there were 14.5 million zero-dose children globally. Zero-dose means those who have no diphtheria, pertussis, tetanus, the first vaccination in the series. And I think it's important to highlight the disproportionate coverage in some countries. 10 countries account for 60% of these zero-dose children. Indeed, only 83% of children in 2023 received their first measles dose, and only 74% their second. It's important also to note that for measles, a higher coverage rate is required for herd immunity, 95%. And you can see in this chart that indeed in 2023, coverage rates have not resumed to 2019 levels. So unfortunately, coverage rates have always been unequal, disproportionately impacting fragile, conflict, and vulnerable countries in vulnerable settings, with approximately half of unvaccinated children living in such settings in 31 countries. And many of these countries have had a decline in coverage rate since 2019. You can see in the chart here that the orange countries are those with fragile contexts and blue are other countries. And a high number of zero-dose children are within the orange countries. This is not a map of the entire world, but as it is our operational areas, this is just an illustration to show the challenges with measles coverage, specifically in 2023. You can see all those countries in red have low coverage rates where there will be high risk of outbreak. In fact, almost all of the countries where MSF Spain is operational. And so the question is why? What are some of the reasons for some of these low coverage rates and for challenges with outbreak? So for many years, MSF and humanitarian actors have faced significantly and increasingly complex barriers and challenges to conduct different types of vaccination activities. So this includes both to support the routine immunization activities as well as catch-up and when outbreaks occur. So there are significant needs, but at the same time, humanitarian space and access to vaccines is shrinking. What this means is MSF and others face a continuous cycle of repeated outbreaks with difficulty to respond appropriately with medical countermeasures, vaccination being one of the most important, and sometimes even more difficulty to conduct preventative activities. So there are many challenges, and I think the other presenters will discuss some of these in more detail, but I've put a concise list of some of the key ones here. So in terms of access to vaccines, this is a complex challenge, but for humanitarians specifically, I can speak to. Some of these challenges include barriers to importation, limited access to Ministry of Health, country vaccines, logistic challenges. This means cold chain and other difficulties getting vaccinations to difficult to reach areas and populations most in need. This also means access to populations due to complex conflict situations, physical access barriers, and permission to be able to conduct needed activities, administrative and other challenges, and these challenges compile and make for a difficult situation to negotiate access. In addition, there are policy restrictions, and this includes limitations on who humanitarians and others can vaccinate. So often only up to the age of 11 months or 2 years is permissible for vaccination, whereas it can be quite effective to vaccinate at least up to the age of 5, if not higher, in some specific contexts, in addition to strategies. So that means who will be covered, whether the activities will only be at the facility level or also in the community level, which areas are covered. So there are many different policy limitations and restrictions. In addition, in humanitarian settings, it's essential that there are flexibilities in place to allow maximum coverage to take all opportunities to vaccinate. So this means financial flexibility, strategy, as mentioned, expansion of coverage, age groups, locations, approaches in terms of where the activities take place. And one of the challenges is limited implementation of available flexibilities, even where they do exist in theory. The reality is they don't necessarily become implemented in the way that's most needed. As an illustrative example about the particular impact in conflict situations, not unique to Sudan and Gaza, but often when there's severe onset of conflict, there's disruption of all health activities, including routine immunization. So you can see a sharp drop in coverage in these two acute conflict settings. And what this means is that there need to be adapted approaches in order to reach those difficult to reach in these settings, in order to conduct catch-up activities, and where needed to conduct outbreak response activities. So I'll highlight a few examples of to highlight some of the challenges covered. However, I know some of the other speakers will discuss these contexts in more detail, so I will just do a quick overview. So in terms of access to vaccines and populations, Sudan is a really good example of both. I believe my colleague will discuss in more detail, but just to quickly highlight some of the points. In Darfur, Sudan, it's an area where MSF and others face extremely difficult access to the population, and also in the ability to be able to have supplies available for the population. This is due to restrictions on importation due to the conflict situation and control by different parties to the conflict. One difficulty is partnership with the Federal Ministry of Health, which means that some areas may be more difficult to reach. The supply route mainly comes via Port Sudan, and this means extreme access difficulties for the supply, particularly during some times of the year and because of the conflict situation with destroyed infrastructure. While some vaccinations have arrived, they arrive in waves, so not necessarily enough at the same time, not necessarily with regularity. And this means that the EPI, the routine activities, are difficult to maintain. And this means that there's high risk of outbreak. And in fact, there have been outbreak situations. In addition, because of the destruction of health facilities, there has also been disruption of cold chain and other infrastructure, making it difficult to ensure the effectiveness of vaccinations. While in theory, it should be possible to import via Chad, which is logistically closer, there are difficulties due to the conflict context to do so. Another example, which I will not go into detail on because I believe another presenter will discuss South Sudan in more detail, to highlight the difficulties with access to vaccines, is one outbreak situation that MSF faced in 2023 in Yambio. We had a measles outbreak declared in January. However, there were difficulties getting sufficient supply to be able to have the vaccinations to cut transmission. So unfortunately, it took over 4 months or nearly 4 months for the vaccinations to arrive. And this means that during this time, the facilities became overwhelmed because transmission had not been cut. And unfortunately, there were additional people falling ill and some people died. Importantly for MSF and others during this time, this also meant that critical humanitarian bandwidth was lost in trying to negotiate for vaccination supply, while we really needed to be able to focus on the outbreak response. So this has shown the importance to be able to have pre-positioned vaccination stockpiles and pre-agreed frameworks. In addition, it has also underscored the specific supply challenges for outbreak response, which may not be as available as those for routine. This is really essential to minimize infection, outbreak, and death. The third example that I'll highlight is from Baidoa, Somalia. To put it in context, Baidoa is a location of Somalia where many people arrive after not having had healthcare for many years, if ever, due to the conflict situation, due to the security situation, due to the breakdown of the health system, due to the conflict. And so many people arrive even up to the age of 15 who may have never had access to vaccination. Under the current guidelines, the age group has been expanded under the Big Catch-up, which is a large program that expands the age coverage group to allow for more vaccination coverage. And this is extremely important in places like Baidoa to allow for more coverage of those up to the age of 5, which would normally only be up to the age of 11 months or 2 years, depending on the antigen. Just a quick illustration as to why a high portion of those admitted, in fact, were over the age of 5, 40%, illustrating the need for such flexibilities and illustrating the need for adaptations to be made in responses that are specific to conflict and humanitarian settings. That a one-size-fits-all approach to vaccination is not necessarily conducive to ensuring the most vulnerable are reached. Just to wrap up before moving on to the next speaker, overall, some of our key messages are there's a need to find solutions for these barriers at all levels. So it's not only enough at national level, but also subnational level, which have different processes in place, different actors who are participating in the response, as well as regional and international level in terms of global supply availability, logistics, and financial mechanisms that ensure the availability of doses and effective responses. A key concern for MSF is ensuring humanitarian space to vaccinate and respond to outbreaks. So this means ensuring access to populations, doses, and involvement in humanitarians in the development of the strategy, the implementation. So this includes availability of supply for humanitarians, for supporting the routine where appropriate catch-up activities, as well as for outbreak response when they occur. And these should be deployed in a rapid and effective way with sufficient doses to cut transmission and reduce deaths. There should be, where appropriate, agreements in place on these different aspects, both in terms of ensuring humanitarians are allowed to vaccinate and for the provision of supply. As illustrated by some of these examples, responses need to be agile and flexible. They need to respond to the actual situation that's occurring, including if you have unvaccinated up to the age of 5 or even beyond. And in terms of the specifics of the conflict, maybe people have never had access to healthcare, maybe people are not able to reach facilities, and strategies need to be community-centered, decentralized. Essentially, there need to be increased opportunities to vaccinate, and all opportunities need to be taken. So overall, there's a need for an enabling environment at all levels to enable humanitarians and health actors to take all opportunities to vaccinate in order to address the ongoing challenges with outbreak, to ensure catch-up activities, and to strengthen routine vaccination coverage. I'll leave it at that. Thank you.
Okay, thank you, Drew. That was really good overview of the situation, current situation, and then also the number of zero-dose children, and then also the children that is not fully vaccinated is quite worrying, especially in those conflict settings. So I will spare the questions until the end, but then thank you very much for your presentation for now. So I will move to the second presenter, Dr. Keita Yoshi. Could you please get ready your presentation?
Thank you. Hello everyone. Assalamualaikum. Sabah khair from Sudan. Yeah, it is 10 a.m. here. So I say ohayo gozaimasu in Japanese. As introduced, I'm Keita Yoshi. I'm an epidemiologist in MSF, working in Doctors Without Borders. Today I'd like to present a vaccine-related picture in Sudan and our response, particularly in our activity and what we are doing in Furbaranga, West Darfur, Sudan. These are the table contents, including from backgrounds, infectious disease outbreaks. So it's like also kinds of the backgrounds and measles in Furbaranga situations and our actions, challenges we face, we'd like to spot it, and resources available. Here's a brief context that surrounds the Sudan currently. Sudan is facing a severe humanitarian crisis due to ongoing conflict between the Sudanese armed force called SAF and the Rapid Support Forces called RSF, which is like an armed organization since April 2023. About 25 million people, and which is updated right now, 30.4 million, as I searched yesterday in February 2025, needs humanitarian assistance, according to UN estimates. And 17.7 million are facing acute food insecurity. In addition, the conflict has displaced over 8.6 million estimated, making Sudan the largest displacement crisis in the world. In addition, 2.8 million people displaced from Sudan to other countries, as is already discussed in the previous speaker, according to UNHCR as well. And these two events occurs a lot of health problems. Particularly, we'd like to introduce these two problems, such as the malnutrition for children aged 6 to 59 months old, and lower vaccination coverage, followed by the absence of or collapse of EPI system. In response to this crisis, MSF is trying to have a presence across Sudan, back and forth because of conflict and COVID-19. And currently we are working in 12 states, roughly speaking, in East and West Sudan, delivering various healthcare depending on the context. I'm currently in Furbaranga, the West Darfur state, as is shown in blue triangle, just next to Chad. Briefly speaking, our project started working for delivering healthcare services, particularly in malnutrition, pediatric, malaria, and reproductive health since May 2024. Currently, we face an outbreak of an infectious disease called measles, so-called in Japanese mashing. Recently, West Darfur state faces the overall West Darfur state faces the measles outbreak, which is a common infectious disease in the world. At the field, we should use the term measles suspected cases, as we mainly judge by symptoms of the patients, which includes fever, rash, cough, runny nose, and conjunctivitis, red eyes. Transmission occurs via air, like via cough, sneeze, etc., which is similar to COVID-19. It has a huge number of burden in humans. Estimated by WHO, presents 107,500 people deaths by measles in 2023. Most importantly, this disease is vaccine preventable, and WHO recommends 2 doses inoculation for children at the age of 9 to 12 months for the first shot and 15 to 18 months for the second shot. The global average of completion of first dose is 83% according to WHO, the data in 2023. Here in Forbaranga, our project responds to the measles outbreak. We are working in a so-called Forbaranga hospital, so it's like a regional area of hospital to receive a lot of patients. The upper figure, you can see in the figure, is called epicurve, describing the number of cases per week. So the very recent one, the week 15, corresponds to the week from 6 April to 7 to 13 April. So yeah, you can easily understand that we are still in a growing wave in terms of number of cases. The bottom figure is age-specific attack rates, and this implies that the children, specifically aged between 6 to 8, 9 to 11, and 12 to 59 months old, respectively, are more vulnerable than on average due to many reasons, including lack of a proper EPI system, as I showed in the previous slide, as well as the behavioral, probably, and biological reasons. Indeed, we also provide medical care in Forbaranga Hospital. This is the photo that of our measles isolation unit in the hospital. Patients with measles who have complicated cases such as pneumonia, conjunctivitis, candidiasis, and acute otitis media. This should be the medical term, so forgive me to speak in Japanese. So people who have Haien and Ketsumakuen and Candida-sho and Chujien, etc. So there are some criteria to judge the patients with complications will be isolated and managed in this kind of unit. Currently, we have 20 beds in our isolation unit. You can see like a tent and a lot of patients. You can see the beds here to the inside, and the patients were hospitalized. But recently, due to the massive cases arrival, our bed occupancy rate sometimes exceeds 100%. So therefore we are working to strengthen our capacity now, both substantial and human resources. I mean, to giving the training to the medical doctors to treat more number of patients, and as well the number to import tents and the beds to strengthen the bed capacity as well. Regarding the vaccination, we take a data of these measles cases if they are vaccinated by measles vaccination or not. As of 14th April, about 90% of patients were not covered by measles vaccination. As we don't know the vaccination coverage per population, we can't draw any conclusion from this figure. However, assuming that the population vaccination coverage should be higher than 10% for sure, and I hope. And as I told you in the background, should be less than the global average, let's say 83%. We can say that the vaccinated population could be protected from measles infection. So I mean, the vaccine will work to prevent the infection for sure. The non-vaccinated population. However, it's still the vaccination coverage in the population will be far from the WHO global average, because it's hard to assume that the people are protected. 83% of the people protected by vaccination, inferred from this figure. To respond to the measles outbreak, MSF is also preparing for a reactive mass vaccination campaign. A lot, you can see as in this picture, which I took in our office, that a lot of freezers and ice packs will be used for maintaining the quality of vaccine, as you've seen in the photo. Oh, sorry, it's duplicated. To realize the campaign, a lot of efforts are made actually, such as supply and logistics, negotiation with Ministry of Health, with HR and venue. internal discussion for promotion of the campaign, etc. So we are now preparing, and the mass vaccination campaign is to be launched probably next week, or yeah, hopefully next week. Here are the challenges. Of course, we have a lot of challenges, but I pick the ones who are majorly we are facing. Following to the conflict, it is obvious that the humanitarian actors who do not secure themselves enough have to evacuate, but the demands are increasing at the field. Therefore, as well as other activities, vaccination delivery are also affected due to the less number of humanitarian actors. Secondary, the smaller number of actors also affect the supply of the vaccination. For example, the provider of the vaccination keeping the vaccines in a certain range of temperature, so-called like 2 to 8 degrees, to maintain the quality of the vaccine, so that we can use it at the field. And to provide the vaccine to the beneficiaries, we need a lot of actors and support, and we would need a big effort to fill the gap once the key stakeholder will be absent. The final point, the vulnerable public health services and lab capacity at local. For example, in measles cases in Forbaranga, many of peripheral primary healthcare units run by Ministry of Health surrounding the Forbaranga hospital does not actually treat cases well. Rather, they often advise patients to go to hospital without treatment, with or without treatment. Also, to diagnose measles more clearly, a fine laboratory will be essential, but we don't have, unfortunately, in Forbaranga or in West Alpul. Currently, we send the samples to Port Sudan, more than 2,000 kilometers away from here. It's like Eastern Sudan, to wait for the confirmation of measles. So that's why we use the cases as measles suspected cases, as we can't confirm currently. However, of course, it takes too much time for delivery of the samples and to clarify and to report the results. Here's the testimony. Here's the last slide, I guess. Here's the testimony urging the necessity of vaccination from local MOH staff. I don't go through all, but what I want to say in this slide is that people at the field also understand the efficacy of the vaccination. However, we need to overcome a lot of challenges, as I show, part of which I showed you in this slide. We are working to make no one left behind. However, your participation will give us a power in whatever kinds of engagements, not only joining, but also to know better, to tell the situation to your friends, or to propagation in SNS or whatever, to the nation, whatever. We would highly appreciate your attendance to this session to know what's happening at the field and what's happening in the vaccination environment of the surroundings. Environment of the vaccination. Finally, I forgot this. Finally, the several contents in this presentation were taken from the advocative document called The Urgent Need to Prioritize Children's Vaccination, a call to action issued by MSF Sudan. Unfortunately, it's not open for public, but if you're interested, please just email medical@tokyo.msf.org so that the organizer will share the document to you to let you understand much more better what's ongoing at the field. So thank you for your attention, and I wish you a happy day. Thank you.
Thank you, Dr. Yoshi. It was a very good presentation and really, really clear to understand the current situation in Western Darfur. And it is actually also worrying to see that the actual cases are rising. So the outbreak is ongoing. So we understand there are several challenges regarding the lack of humanitarian actors, and also the logistics side, and also the diagnostics of measles. Thank you, Dr. Yoshi, and also for the document. If anyone is interested in, please let us know for this email address that is just shared on the chat. We can share the document with you. Okay, so we would like to move to the next presenter. So we have heard 2 presentations from MSF, so we would like to hear the side from the government. So Dr. Kediende, if you can get your presentation ready, please start your presentation.
Hello?
Yes, we can hear you. Yes, we can.
All right.
Yes, please start. Thank you.
Yeah, I was saying my name is Kediende Chong. I work for the Ministry of Health of the Republic of South Sudan. as the Director General for Preventive Health Services and Emergency Response. I'm happy to share with you the South Sudan experience and in the context of a humanitarian situation that South Sudan is in. And I'm happy also to share not only the achievements that we are making, but also the challenges. As we all know, South Sudan, like many other countries, is among those experiencing the humanitarian situation for decades. A bit of a background of South Sudan. South Sudan, of course, is still being known as one of the new or youngest countries, and became independent in 2011, and is divided into 10 states and 3 administrative areas. And out of that, we have a total of 80 counties. The healthcare service delivery in this country is facilitated through health facility, as well, which are also divided into primary and secondary and tertiary, and also a community health program, which is known as Boma Health Initiative. We in South Sudan have been known as one of those countries with the worst health indicators in the world, particularly the maternal mortality, as well as the child and infant mortalities. We do have malaria and respiratory tract infections and diarrhea being the main causes of morbidity and death in the country. Efforts are being made to ensure more integration of those vertical programs that are funded through the donor investments. The Minister of Health in South Sudan has adopted the District Health Information System, that is referred to as DHIS2, as the only national health information reporting platform for the country. Looking at the experience in South Sudan in terms of vaccination and its performance, just to take Penta and measles, and of course we'll talk of malaria. We're among the countries that has started the malaria vaccination. And as our country is currently facing cholera outbreak, we'll also share with you what is happening with the oral cholera vaccination that is happening in the country. Sarah, allow me to also say, with all the humanitarian factors you have alluded to at the beginning of the session, all of them apply to South Sudan, being conflict, being climate change, being outbreaks in terms of multiple outbreaks the country is facing, being displacement from neighboring countries such as Sudan. The country is hosting a good number of refugees, as well as returnees, which are own citizens that are returning from the Sudan. So with all these factors, I can confirm that the immunization coverage in South Sudan is still quite low. And we have just taken the last 3 months data from our system to share here and to also see in terms of comparison. So as I mentioned, we have 10 states and 3 administrative areas. You can see them here with the data that we are sharing with regards to Penta for the first quarter of this year compared to the first quarter of 2024. And you could see even within the same period of 1 year from the first quarter of last year to the first quarter of this year, you could see a huge variation that shows further decline in the immunization coverage when it comes to Penta. And I can see from the slides, you will see there are some few states that are actually doing much worse than others. And in particular, you could see Jonglei State. Jonglei State is one of the biggest states in this country, but is very much affected by the humanitarian factors, including the flooding that has been there over the last 4 or 5 years. Constantly, we have also been having the conflict, the civil war, and this conflict is affecting Jonglei as well as Upper Nile State. You can also see that. among the states that are very much affected. We can also see Pibor administrative area is also within the Jongole area, although it is a separate administrative unit. We can also see some areas that are also not performing well. It's also because they are affected by conflict. And you can see Western Bahr al-Ghazal, you can also see the performance there is not adequately maintained, as well as some parts of Eastern Equatoria and also, as I mentioned, Upper Nile, and particularly the first quarter of this year, 2025. If we can also look at the next slide, you will also see a much similar situation when we are looking at measles. The coverage for measles, comparatively looking at the quarter one of 2024 compared to quarter one of 2025 this year, you can similarly see a poor performance with some of those states that are very much affected. And I can still mention Jongole state, you can see that. Upper Nile state, you can still see the same picture. You can also see a similar situation with the Western Bahr al-Ghazal and also Central Equatoria and Eastern Equatoria being affected mostly by conflict, but also partly the climate change, which is actually affecting South Sudan very much from 2021 or 2020 until now. We have been constantly having this flooding every year. Looking at the next slide as well, you will also see if we look at how we are trying to look at the vaccine uptake on monthly basis, we can actually tell you and our participants from the system. This is what the picture we are seeing. You can see the Penta 1 doses that are given and including the Penta 3 doses that are given. You could see some slight variation, but honestly speaking, the performance over the last three months is very much worrying. And if people are following the news, you would still see that the humanitarian situation in South Sudan has been actually characterized with more tensions over the last few months. And that is directly reflected in the performance and the vaccine monthly uptake, as we can see from this slide. Looking at the next slide as well, you can also see for measles is a similar declining performance for the last 3 months, which is the first quarter of 2025, compared to the first quarter of 2024. And this is very much related to all the factors that we have talked about, and particularly the conflict situation in those specific areas which we talked to about Jongole and some parts of most of Jongole, Upper Nile, Unity State, and some parts of Equatoria. Looking at the next slide as well, when we talk of malaria, of course, not the whole country that is actually accessing the malaria vaccine. Malaria vaccine is approved in the first phase for 28 counties. And among those counties, we have selected some few to show the monthly uptake. Unfortunately, we are not able to sustain the uptake through the 3 doses. So you could see the malaria first dose that is given. You could still see that at some point it started well, but unfortunately, the subsequent doses, the performance and the uptake has declined significantly. Part of this is actually related to the community engagement aspect and risk communication activities that are not really able to access all the locations given the limitations of the humanitarian factors we have just outlined. Again, we are looking at the same period of 3 months of first quarter of 2025 this year, compared, in each month from January to February to monitor and see the vaccine uptake. Looking at the following slide, here we are talking of cholera oral vaccination. Many of you might have heard that South Sudan from December 2028, September 2028, December 28th, 2024, which is actually a couple of months back. We are now almost around 6 months since the time we declared the cholera outbreak on the 28th of September 2024. The outbreak has really been hitting the country very, very, very much. The cases are now totaling to around close to 50,000. And despite all the efforts that are being made, but the humanitarian situation in most of the locations that are affected is not allowing the response activities to be effectively implemented. We have used the pillar approach, and one of those includes the use of the oral cholera vaccination. And we are thankful to the international coordination group, whereby we were able to access vaccines, and we received, approval for close to 7.5 million doses of oral cholera vaccines, and that is for a target group of around 7.5 people. And out of this, more than 6 million doses have been delivered to the counties that are affected, and those are around 34 counties out of the 80 counties that I mentioned earlier. And 24 counties out of the 34 counties have completed the vaccination, and that has given us a coverage of close to 70% in terms of the population, and also in terms of the counties that have implemented. We have actually are around those that are still implementing. Added to those who have completed, we are at around 88% of the counties are now either completed or they are still implementing the vaccination campaign. Looking at this coverage, we expect to see, of course, and we are seeing a clear or significant decline in number of the new cases across a good number of counties. However, there are still new counties that the epidemic is spreading to, and we are still in the process to apply for more doses to cover the new counties that are being affected. To conclude, I want to also mention a few of those challenges that are encountered during the vaccination in this humanitarian setting, and in particular, South Sudan. One of the major challenges, in fact, is the inadequate coordination among the various stakeholders, which hinders not only the vaccination, but even the outbreak response in the country. South Sudan has many humanitarian actors, many implementing partners, but unfortunately, the coordination has not been effectively done, and that is resulting in more missed opportunities and waste in terms of efforts, resources, and time. Multiple disease outbreaks, and in this country we have been facing a lot of outbreaks, and that is also causing a lot of overload and overstretching in terms of response efforts. Resource limitations, and we all know, Sarah, you mentioned earlier, the funding constraints that are happening now within the donor community, and especially the countries that are actually the main supporters of humanitarian aid, and that is actually affecting South Sudan as well. But more importantly, a lack or limited sustainable domestic funding, which hampers operational capacity to conduct reactive campaigns, and especially when we are doing the vaccination, such as cholera vaccination campaign that we are currently doing. We also have issues in terms of data management system, which is still weak. And of course, here we talk of the late and incomplete transmission of the vaccination data due to many other factors. And of course, inadequate systems that actually is to say affecting the trend and the analysis of the outbreak coordination, and for us to document timely what achievement and progress that is being made. We also speak of inadequate training and high turnover of staff. There is a serious shortage of trained personnel in this country. And of course, that results in inadequate pre-campaign trainings that are meant to be done. Whenever we train people, there is an issue of sustainability or retention of the personnel. But more importantly, even the community volunteers that we train, they need to be incentivized, they need to be motivated. And if that doesn't happen, you can't get them. You train for this campaign. Next month, you are having another campaign. You will get yourself forced to train more people again, because there is this kind of turnover, which wasn't in the issue of lack of proper orientation as well. But more importantly, it is a retention issue. We have also delayed integration of critical vaccines in this country of ours. And that include, of course, issues around yellow fever, meningococcal. We are among the countries that falls within the meningitic belt. And of course, we also wanted to see integration into the routine immunization program. We also have talked about the limited community engagement, which is very, 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 very important. You know, use of the NGOs and the humanitarian partners is also creating a mindset whereby the health issues and addressing the health problems is being viewed in the communities as if it is a business of the organizations and a business of the government. And we are calling here in such a setting, there should be one of those challenges that is being faced is always how best we can involve the communities. Last, in the context of South Sudan, is the poor infrastructure. And that includes even the communication. The communication coverage or the phone coverage or internet coverage in this country is less than 20%. And that, of course, results in weak communication system, delay in reporting, and the coordination. However, we are also happy to say that the community system that we have started to use, plus the fact that we are pushing for investment in the health system, the national system, requires us to ensure sustainability of the interventions and the responses that are being made. Otherwise, I want to say thank you very much, and I stopped here. Back to you, Sarah.
Great. Thank you very much, Dr. Kediende, for this such a comprehensive overview of the situation in South Sudan. It was very, very well understood. And indeed, as you mentioned, you know, there's all these humanitarian challenges, and then also non-humanitarian challenges like climate change is hitting almost the hardest in South Sudan. And definitely, this is exactly why we wanted to have you as a presenter, and then wanted you to share your experiences here. Thank you very much. Just one supplementary information for those who are non-medical audience. The Penta vaccination that you mentioned in the presentation, this is a combination vaccine that is to protect against 5 different diseases: diphtheria, tetanus, whooping cough, which is hyakunichizeki in Japanese, and hepatitis B and Haemophilus influenza. So just for your information. So great. We would like to, discuss more about the challenges and how to move way forward. But before that, we would like to hear a little bit more about Japan. So the next presenter is Dr. Ujiie.
Thank you for inviting me. So I'm Mugen Ujiie. So I'm an ID physician working at the National Center for Global Health and Medicine, government hospital, so in Japan. So, and also, so from tomorrow, so World Immunization Week will be started. So that's the reason. So I use this front picture of the slide. Okay. Okay. So in this presentation, so I will speak about so in the beginning of the presentation, so I will explain how important vaccines are. And also I will show some examples of the current outbreak setting. So especially the measles and mpox, so both are vaccine preventable diseases. And so in the last of my presentation, so I will list several barriers and the factors to disrupt the vaccination program, so in humanitarian crisis. But I think so these kind of factors already experts explained in previous presentation. So that's the reason. So I additionally added some slides to share my opinions regarding the vaccine hesitancy. Okay, so this slide showing there how the vaccines are important. So actually, vaccines can prevent infection and death mortality, but actually, vaccines cannot realize that they are prevented from the vaccine. So that's the reason. So we need to understand how vaccine effective. So by the objective data, the epidemiological data. So left figure showing after utilizing the measles vaccine, the reported measles cases are dramatically decreased. So that's kind of the impact has influencing their public health issues. And also, vaccine can prevent the personal infection, but that kind of the benefit is not limited to the vaccinee. So it's also affect the neighborhood, such as our family members and their health providers. So I love these pictures. So by receiving the vaccines, children can prevent their vaccine. So that's the reason. So they can continue to be educated at school. And then family members don't need to take care of their sick children. So that's the reason. So they can continue to work. And also, health providers' burden will be reduced. Then social activity will be improved and promoted. So this is a good cycle. So that's the reason. So vaccines are most cost-effective medical interventions in any settings. But in humanitarian crisis setting, everything is very limited. So if some person is sick, maybe some medical access will be limited. So fewer health provider can see patients, and also available medication and treatment available. So in this humanitarian crisis setting. So that's the reason. So many of the factors, making the worsening, in the outbreak setting. So that's the reason. So we need to keep the high coverage of the vaccination. So current situation, vaccine coverage are gradually decreasing. So after COVID-19 pandemic. But we need to realize that vaccination in the humanitarian setting is not just an intervention, so it's life-saving priority. So this is showing the coverage of the measles. So previous presenter, Drew already presented. So as I show you, coverage of the measles, especially first dose of measles-contained vaccines, is a little bit reduced. And the number of no vaccine of the measles increasing from the 2019. Then in the beginning of the pandemic situation, we put under strict preventive measures to prevent the spreading the COVID-19. So that's the reason all of the infectious diseases are underreported, and also report is also decreased. But after lifting the restrictions, under international travel restarted. So the reported number of the measles increasing. So these kind of things also related to the vaccine coverage. This trend is happened even in Japan. So this figure showing the orange line is showing the coverage of the first dose of the measles vaccine. And there also national targeted coverage, is defined as 95%. So before COVID-19, it is above more than targeted coverage rate. But after that, it's a little bit decreased, and also second vaccination, before school age, it's also decreased. And compared with the before COVID-19 pandemic, the reported number of the measles is still small, but gradually, so increasing. Let me these things, and also this spring, so we have more cases, and also we need to afraid of the more big outbreak. And also, I would like to explain about the mpox situation. So actually, so first human infected cases are reported in 1970. So it's more than 50 years ago. And also, until 2022, so two types of the virus of the mpox virus circulated in Central Africa and West Africa. But so since 2022, so mutated clade 2B virus of the mpox virus, so spread it so globally, so especially in MSM. So most of the cases are the male cases and the adult cases. But the current situation is now changing. So from DRC, since September 2023, so another muted grade 1B virus spreading in the Africa. So this characteristics is different from the grade 2B. This showing the reported cases. So in Africa, so in few years, the reported cases of the mpox, so increasing now. And also, this grade 1B virus is affected in mostly children and both sexes. So that's kind of the things very different from the grade 2B mpox cases. And the background of the current outbreak of the mpox. So actually, as I told you, so this virus was detected more than 50 years ago, but so far, so we didn't have the so good medical countermeasures. So because there were no motivated, so pharmaceutical company were not motivated to prevent the mpox, especially in African countries. So these kind of things would be the one issue. And also, end of the smallpox eradication is related. So smallpox virus, variola virus is so same family virus with mpox virus, so also pox virus. So that's the reason. So smallpox vaccine would be partially effective, so to prevent from the mpox. So after eradication of the smallpox in 1980, so global vaccination program was suspended. So these kind of things would be related to the current outbreak. Also, so stigmatizations would be the factor. So actually, so smallpox has patient has a skin lesions, and also grade 2B virus was spread in especially in MSM people. But through the sexual contact. So these kind of things can be factor. So stigmatization and causing the avoidance of the healthcare access and vaccination. And so smallpox vaccines are so effective even against mpox, but so only 2 vaccines are available in the world. So WHO are listed as an emergency use, MVA-BN and LC16M8. So the later one, LC16M8, were developed in Japan so in 1975 and also currently available. So that's the reason. So between the DRC and Japanese government, so there was a contract. So to donate the 3,050,000 doses of the mpox virus, mpox vaccines, LC16M8. So would be so donated to the DRC. And currently, so only 50,000 doses are already arrived in Kinshasa. But so in my understanding, so another 3 million doses would be transferred to the DRC. So in short period, I think. Then also SC68 is a very how can I say, specific vaccine. So it's very not usual vaccine. So inoculation method. So we don't use a needle and syringe. So we need to use a bifurcated needle. So to inoculate. So in the skin. So that's the reason. So we went to DRC. So how to use this vaccine, and also to conduct the trainers of training. So we conducted symposium. So with the stakeholders in DRC, and I explained how to use this vaccine and how to treat the patients after vaccinations. And so this kind of information would be spread in DRC for conducting the mass vaccination. And also explained, listed some of the factors of barriers for the vaccination, but maybe these kind of things already discussed in the previous presenters. So let me skip this. But anyway, there are several issues to disrupt the vaccination. So in low-income countries, but so that's the reason. So we need multiple interventions. So by each. So these kind of obstacles need to be intervened by the appropriate way. But as I told you, I'm a clinician, so that's the reason. So I'm afraid of the vaccine hesitancy in the clinical setting. So even in 2019, so WHO explained that vaccine hesitancy would be the great threats to the global health. So in this year, there were big outbreaks of the measles in the globally. Actually, vaccines vaccine are effective only after they are administered. So that's the reason. So even after developing the good vaccine, so it should be used appropriately. And the anthropologist Heidi Larsen explained. So that's kind of the how can I say? So vaccination programs, the operation, should be based on the trustness, between the vaccinee and the vacciners. So these kind of the things are very important in the clinical setting. And I also believe medical providers such as doctors, nurses have the important role to build such kind of trustful relationship with the targeted population of the vaccination. So that's the reason. So I think communication and education, such kind of intervention would be very important as our health providers.
So thank you so much. At the moment, I don't see Ms. Sarah Wanyoike of WHO is not joining us yet. So we will just continue with the session. So at the moment, actually, we only have 15 minutes left in this session. So I don't see any question in the chat at the moment. So if you have any questions, please write them in the chat. We will try to ask the panelists. So we can move to the discussion topic. Yep. So maybe it was very interesting to hear the different versions, different varieties of challenges has been discussed either globally, in a complex settings, also in Sudan and South Sudan specifically, and also including Japan and worldwide. But then in order to disclose the gap and access those who are vulnerable and, necessary to reach, how do what kind of measures, what kind of activities and support is necessary from both public, but also from private sectors? I would like to ask each speakers, each panelist, to discuss a little bit from your perspective, your role, what is necessary to close the gap in terms of public and private sectors activities. So maybe as you were the first presenter, Drew, maybe I can ask you first.
Yeah, that's a great question. Many challenges and also opportunities, I think, outlined. So I think specifically for humanitarian conflict fragile settings, there are a lot of enablers that can be put into place. So one that was discussed a lot in different ways were the different mechanisms and systems that can be improved, whether that's the health system, the cold chain, the logistics, having the support both in terms of the longer term infrastructure to countries that have faced humanitarian and other challenges, just to have a baseline, to have basic availability of doses, as well as trained and available health workers. And then more specifically adapted to onset of conflict, there can be approaches that are ready and deployable, whether that's mobile responses in order to do catch-up activities or outbreak response, and the resources already in place. I know that's been mentioned by different speakers, both international financial availability of resources and domestic, and there's a huge gap and not clear solutions, but that's clearly an enabler to be able to address them. And then at the policy and strategy level, so there's a big opportunity at the global and country level with Gavi 6.0, the fragility and humanitarian approach that is supposed to take into account some of these challenges, put in place flexibilities, adaptations to ensure available doses, ensure that there's access and including, for example, pre-positioning of stock. In terms of availability of supply, from our perspective, the supply, there are many challenges, but specifically for outbreak is a major challenge. The quantification, ready deployment to have timely outbreak response at all levels is essential, as well as the production of vaccines at the global level, and so all the systems in place. With the current disruptions, I think there are questions about what that will look like, both for existing vaccines and for innovation for new vaccines at the regional, global levels. And then I think for MSF, one of the key, and I think mentioned by some of the other speakers, a key component is community involvement to address some of the barriers, to address vaccine hesitancy, to address access, to address many of the challenges, involvement of the community in the different types of responses needed. Maybe I'll leave it at that.
Great, thank you. Yes, I can see that there are multiple measures that needs to be taken. But how about maybe I can ask Dr. Yoshi, what do you think from your perspective, maybe from the field?
So some of the points I'd like to deliver is actually covered by Dr. Drew about particularly about the challenges in logistics and the supply. We face a lot of challenges in delivering the vaccine from the provider to the field where we apply the vaccination. And such as to maintain the degrees and the trucks and to maintain the road conditions with a secure to have us to secure the movement. We made a lot of efforts. Maybe I can add some points about the capacity building of the local authorities, such as the MOH and the health facilities at the local, operated by run or operated by MOH or other organizations, because we face a lot of disparities between us MOH, MSF, and the other other organizations or other health facilities about the quality of the medications or quality of the medical healthcare services delivered, and also other following outcomes like the data collections or the standards of the hygiene and sanitation that can comes after the medical care. Yeah, so for that point, MSF has one of the higher standards ever I've seen. Therefore, we can support to help them build the capacity so that they can run by their own, with much more better quality to deliver the better quality of healthcare to the community or to the inhabitants. And oh yeah, about the cooperation with a lot of actors. Yeah, as introduced somewhere in the session, the list number of actors, the actors are changing due to some external factors, and we need to adapt to the changing condition to maintain their healthcare delivery. Otherwise, the people will be suffered. And to maintain that, the coordinations and to direct to build a policy or strategify how to deliver the healthcare properly will be necessary and should be discussed among the stakeholders that are in the field level or in the coordination level or in the HQ level from everywhere in the world. The stakeholders will be necessary to discuss a proper to form a proper agreement to deliver much more friendly healthcare services, including vaccination. Maybe yes, that's all from my side.
Thank you so much. But yes, indeed, again, quite a lot of points has been listed, and improving the quality of medical care is definitely an important factor for the local health facilities. And then also, yes, data management, Dr. Kediende already mentioned, but I think it is also definitely an important part for the outbreak responses, as you are the epidemiologist and working in a project. Yes, and the cooperation with other actors, definitely. This is exactly the theme of this Congress. So thanks for mentioning it. Yes, but we would like to ask, I'd like to hear from the government's point of view. So could you also give us your opinion, Dr. Kediende, from South Sudan government point of view? Thank you.
Thank you, Sarah, and all the colleagues. Yeah, with us, from our perspective, there are a lot of things that we believe if they could change and be done differently. Number one is all the humanitarian actors, and particularly the non-government. We really need to admit the fact that local engagement and support and building on the local, whether they are staff, whether it's a system, is the only way that we can not only sustain the interventions and the response that we are making, but also to encourage more ownership, and ensure that the system is resilient, the response that we are making. And I can give just one example. In the context of South Sudan, where we have so many humanitarian actors, international and national, but mostly international organizations, we have always been emphasizing the fact that the funding from the donors is not sustainable whatsoever the case. And the current situation that we have seen is a good example that some decisions can also be sudden the way we have seen them. South Sudan is one of those countries that is affected, but we also look at it as a lesson learned for the actors to start to see the importance of investing and supporting the local system, the local personnel, because in the context of South Sudan, where we have been in conflict, that often results in displacement. So using, for example, the humanitarian actors are mostly depending on the use of international and the regional staff that they bring into the country. In case of any conflict and that results in a displacement from point A to point B, you would see only the population moving from point A to point B. But the humanitarian actors, they mostly will be busy trying to evacuate because they're also bound to protect and ensure safety of their health workers or their personnel. And they will be moved to a nearby location or a neighboring country where we'll even still continue to spend the money and the resources on them. Compared to when you use the local people, when people get displaced, like a midwife or a nurse that gets displaced with the population from point A to point B, the nurse will continue to give anti-malarial injection under the tree. The midwife will continue to attend to unexpected mother under the tree. This, to me, is the only way we can actually ensure that the system is resilient enough. It also makes it more efficient. Honestly speaking, in the context of South Sudan, we mostly use the UN agencies, the international organizations. None of them is really efficient, and I have to be very frank on this. We have always been saying this. The cost of bringing an international and maintain an international here can actually allow us to motivate and sustain more than five who can do a similar job. I'm talking here as a health personnel, working with the health workers, the categories that we have. We can only look for those that are highly specialized to come and also build the capacity of those that we have. On the other hand, I also want to emphasize the importance of really supporting the government. There is no way we can sustain what we can do in any country without engaging the government. And the government must be there to lead and steer the response, whatsoever the case. There are situations whereby humanitarian actors would also want to behave as if they are the one to take the lead. They are the one responsible, and that will not take us anywhere. You know, we must recognize the government of the land. We must also make sure that we are there to support that government. We can't actually behave like we are a government of our own. We are the one in charge. And I always say this, the people of this country, in the case of South Sudan, I believe they're so resilient. We have been through a lot, and support has been coming, but we need the support to come in the way that it recognizes, you know, the local system, the need to have the people being in charge of their own responsibilities. There is no way we can try, or the humanitarian partners from abroad would come and take full responsibility of the lives and the health of the people. It has always to be emphasized that the local and the government and the community must be in charge of their own services. Otherwise, thank you very much.
Thank you, Dr. Kediende, for your really honest opinion. And I really definitely agree with you that we really need to support the local government and build capacity and support them in order to sustain the responses. And you're definitely correct. And I really appreciate your honest opinion, because as an NGO, this is one of the biggest challenges we face. And then this is also, you know, it will impact our future activities. So thank you very much. But last but not least, again, sorry, Dr. Ujie, I would like to hear your opinion as a Japanese medical doctor. What do you think of this question?
Okay, thank you for your question. So if I choose one factor, so to improve the vaccination campaign, so and the vaccine hesitancy, so maybe as you know, so populism led by the United States has been a hot topic recently. But I believe that stable economic support is extremely important. So in order to promote such initiatives, so it will be important to foster public acceptance. The idea of the acting not only for oneself, but also for anyone in need is a fundamental principles of the healthcare. So I believe that this way of thinking is so crucial for improving the situation. That's all for me.
Great, thank you. Yes, definitely. That is most important as well for vaccine hesitancy. Yes. I'm sorry, I just realized that actually our time has run out. So we don't have any question coming into the chat. So we would like to close the session here. So before we go, we would like to have like one word each from each presenters as a closing remarks. So maybe again, I can start from Drew. Thank you.
Yeah, I guess my remark would be, I think we know a lot of the things that need to be changed in order to be more effective to prevent infection and death and to mitigate the impact of outbreak. And it's really just a matter of political will and action at all levels in a coordinated way. Thank you.
Great, thank you. Definitely. Dr. Yoshi, please.
Thank you everyone for your attention and attendance. Yeah, my remark could be you can just react whatever you can do it to change the world. Your contribution, even if it's smaller, you would think it could change the world. So either if it's even if it's not a direct one, if this is like very, very far away, long, indirect one, it could change the people, and it could change like so-called in Japanese like tamatsuki. So people like so you change something, and the people react, which makes the people reactive to change something. So yeah, which makes the bigger power. I would like to announce from the field that here we have a lot of challenges, but we could try to survive and try to maintain our services. So yeah, the field is we are still live, and yeah, it's good for you to hear. Yeah, thank you.
Great, thank you. I see that you wanted to say the chain reaction of the responses. Thank you. Dr. Kediende, please.
Yeah, thank you, Sarah. My last remark, and it's just a reminder, if possible, to always emphasize and remember the principles of aid effectiveness. We know the resources are getting more scarce, are getting more limited, but with the little we get, if we apply and follow the principles of aid effectiveness, work through the systems, priorities of the countries, we will always be able to achieve with the little, we can achieve much more as it is outlined there. Thank you very much.
Thank you so much. Yes. Dr. Ujiye, please.
Okay, thank you for attending to the meeting and so hearing from our presentations. I think thinking and knowing the facts is the first step. So to consider the next step, and so as Dr. Yoshi mentioned, so if it's local act, so if it start. So it spreads so globally. So that's the reason. So I think this is so I believe so this kind of opportunity would be the good chance to do the next step. So and I hope so this kind of discussion so would be so helpful for understanding so for all participants. That's all for me.
Great, thank you very much. And thank you again for all the panelists for spending your time to attend this session. Thank you so much. So this topic of vaccination is so vast and then it's dire that if we don't respond now, we will see a lot of deaths will be caused by infectious outbreaks. So, but then each of our steps may be small, but then altogether, but we work together as an NGO, also WHO or the government, I believe that we can reach those most vulnerable population in the world, and we will leave no one behind in terms of vaccine accesses. So thank you again, and have a great day for you.